Dr. Gautam actually is, as Dr. Renu Chugh is saying, for Bengal, we all, most of the academic part is sort of drifted to East. And Dr. Gautam is a live example of that. He is actually a recipient of Wellbeing Research Grant, RCOG London. He has published many research papers in infertility, hormone therapy, endoscopic surgery, and he has been accredited subspecialty training in reproductive medicine and surgery in level 3 endoscopic surgery. He is medical director of Birth and Advanced Fertility Center, head of gynecoscopy, and he is organizing secretary of a wonderful ISAR 2018 that we all witnessed, and also of ISAR Bengal 2020 to 22. He has been elected member of the ISAR Executive Committee of 2020 to 22. And also, one more thing, he is contesting for the post for ISAR as well. So we wish him as for the librarian of ISAR, and we wish you all the very, very best, Dr. Gautam, and I'm sure it is, we will all, ISAR will be benefited a lot by your presence, and I hand over to you for your talk on endometriosis. Thank you.
Thank you very much, Dr. Jyoti, for that kind introduction. We have been good friends for so many years now. And the other chairperson, Dr. Anupama, thank you for chairing this session. But at the outset, I must say, without Dr. Renu Chugh and Dr. Rakhi Malhotra's initiative, this webinar wouldn't have happened. And I'm ever so grateful to both of you and all other senior members, Dr. Neelam, my very favorite, Dr. Niharika was there. And first of all, getting those words of wisdom from 3 pillars of Foxy. They're very good friends, Narendra, Rishikesh, and Nandita. So Dr. Renu, it was fantastic effort on your part to have all of us, and it gave us so much vision about how we should go forward. And those 6 points by Rishikesh, I actually note them down, and I will have to spread across these visions. Now, the wonderful talk by Dr. Poonam, whom we have known since the Gurgaon conference, which she organized it so efficiently with Dr. Narendra. And then we followed that in Bengal next year. Now, if I could share my screen and then start my talk. I know it's, the evening is not long. Maybe I'm stopping you from my talk and your family, but I will try to be very concise and share my thoughts on this very important topic. Now, endometriosis has been with me for last nearly 30 years, because when I got a seat in MD in Calcutta University, one of my professors told me to do a work on endometriosis. And many others said, you won't get enough cases because in late 1980s, endometriosis was not that common. It wasn't picked up. But we got good number of cases, and I looked at the laparoscopic findings along with the symptom. And as we understood that stage, and which is also practical now, is severe the symptom sometime, lower is the stage. So, we say in Bengali, if you have a small chili, it's very hot. So with endometriosis, sometimes stage 1 and stage 2 can give you more symptoms than stage 3 and stage 4, where the disease is more or less advanced, but the patient has been used to the pain, but this is not always uniformly true. Now, the reason I choose endometriosis and infertility is because infertility is one of those issues. It's affecting so many couples throughout the world. Now, endometriosis will come with either pain or infertility. Now, we shouldn't mix them. I often say this, endometriosis is like driving a car. Okay, now, if you have a car, you have an accelerator and a brake. If you put the brake, even non-effective car, a non-functional car is going to stop and not going to make any accident. But if you suppress the ovarian function, that is putting a brake, endometriosis will be cured. But how that couple is going to get pregnant? That woman is not going to ovulate. So you have to accelerate, stimulate the ovaries. And when you accelerate a dysfunctional car, you are likely to have an accident. So put a brake, repair the car, and then go ahead with the acceleration. Now, with this preamble, if I could take you through why endometriosis causes infertility. Often the environment is abnormal. It could be gross distortion of pelvic anatomy, or it could be microscopic biochemical changes with elevated cytokine and sperm phagocytic substances. Many a time, there is subtle alteration of tubal motility and tubo-ovarian relationship. The eggs we get from these endometriotic patients are often of poor quality. They are incomplete maturation. There are often LH receptor defects, luteinized unruptured follicle syndrome, and low fertilization rate. Endometrium, on the other hand, may not be 100% acceptable for implantation. And people have done research on HOXA10 and 11 gene, and they're not upregulated, which is required for implantation. And finally, during pregnancy, there's chance of miscarriage, or there's a chance of getting a luteal phase defect, and that has also need to be addressed. So the problem is actually multifaceted. It is not just ovary, it's not just endometrium, it is also the environment we need to rectify. Now, how do we manage? Now, this is a flow chart which helps us to decide. If we see patients in stage 1 and stage 2, if the patients are younger, of course, we can give them expectant management. That means you give them just wait and see, tell them what is the fertile period. And often we give them oral ovulogen for ovulation induction, and they try timed intercourse. But more importantly, they should go ahead with superovulation by gonadotrophin and IUI. And this may be before or after laparoscopy. In good old days, laparoscopy was the gold standard, and you must do laparoscopy to diagnose endometriosis and then only treat the patient. But now with the advent of very good ultrasonography, just like we have been listening from Dr. Poonam on in early pregnancy, with 3D ultrasonography with Doppler, we can identify many cases of endometriosis even without doing laparoscopy. If the patient is older, over the age of 35, straight away do ovulation induction and go for IVF. Now, when the patients are in advanced stage 3 and 4 endometriosis, we can do conservative surgical therapy by laparoscopy, if necessary by laparotomy. And if these patients don't get pregnant, then you go ahead with IVF. Now, the patients are diagnosed in different ways. Nowadays, we can detect by the clinical symptoms, we can detect by laparoscopy, we can detect by ultrasound. If we detect by clinical symptoms, we have to do ultrasound or MRI. And then we have two options, either go for surgery or go for IVF. Once we have done the surgery, either they get pregnant or the recurrence of the disease. And if the recurrence of the disease, they go for IVF. Now, if we have detected it by laparoscopy, then definitely we have to treat, because there are many studies which have shown if we have done laparoscopy and just diagnostic laparoscopy and come out not doing anything, vis-a-vis if we do laparoscopic surgery for endometriosis, the success is much better after surgery. Now, many of them will get pregnant. And if they are not pregnant, the next step is IVF. Ultrasound diagnosis, if it is endometrioma, it is picked up very well. Now, it's not all cases, but some cases of endometrioma will require laparoscopic excision, which I'm going to come to you just in a while. And after the surgery, they may get pregnant, or the disease may come back, or even before the disease recurrence, we can go for IVF. Now, let's look at these two treatments separately. So I will first discuss about role of surgery, and then I will discuss the role of ART, because I feel these are the two mainstay of treatment. We should go straight away and give one of these treatment to our patients. Now, laparoscopic surgery has been the gold standard, as I said, but nowadays what we are saying, the widespread popularity is based on uncontrolled studies, and the potential benefit may have been overvalued. Because what we do, what is the human tendency? If you run a laparoscopy, results are good, you publish it. Now, if the results are not good, okay, you stay quiet. So these are uncontrolled studies, because it's unethical to do randomized controlled trial of laparoscopy for patients with established endometriosis, like stage 3, stage 4, because everybody knows the treatment is going to do pain relief and reduce the disease. Now, the likelihood of conception after surgery has to be compared with a background rate of 10 to 15%. So patients with endometriosis, particularly in early endometriosis, they may get pregnant spontaneously. So any treatment we offer has to be more than that. Now, the other thing we currently are discussing is the role of surgery before or after, or as an alternative to assisted conception, needs further evaluation. So before the millennium, we were told surgery is a must. Now, after the millennium, the pendulum has swung on the other side, and they are saying, everybody is saying surgery is not essential. It may be an alternative, but it's not essential that you do surgery before assisted conception. What are the aim of our surgery? We want to excise or fulgurate, even sometime remove the diseased organs. We need to restore the anatomical relationship for good egg pickup, and we should also do something to prevent further adhesion. Now, what are the indications? Of course, mild to moderate endometriosis patients, I shouldn't say should, but may have surgery even they are not in pain. So suppose you have a patient, you do not know, it's an unexplained infertility, you cannot treat. You don't have to do a laparoscopy as a must, but if you have done a laparoscopy, if it is mild to moderate endometriosis, please go ahead and treat. All type of endometriosis with infertility and pain. So anyone who has a pain should have a laparoscopy. And that would not only relieve the pain, but also enhance the chance of pregnancy. Now, if there is a situation that we cannot do oocyte retrieval because of the big size, because of adhesion, because the ovaries are very high up, then we have to do surgery. It is said that any patient who has hydrosalpinx has a lower chance of ART success, and therefore, in these patients, tubal clipping or salpingectomy is a choice, and you can do it only by surgery. Now, some women would not accept ART because of their personal, cultural, religious, economic reasons. So patients will come and say, no, thank you very much. We are not going to do ART, come what may. Dr. Saab, you do something else. Then you don't have any choice other than surgery. Now let's look at the stage of endometriosis differently. Minimum to mild endometriosis, two very good, well-publicized randomized control study. One we call Canadian study, other one Italian study. In the Canadian study, it showed the pregnancy rate is much higher, 36.6% compared to 21.9% if you compare laparoscopic surgery versus just diagnostic laparoscopy. Now, unfortunately, the Italian study didn't support that. They said whether you do surgery or not, that is what I enjoy about science. The science is not always fixed. 2 + 2 is not always 4. But what we were told that if you treat a patient with surgical, when I was young, I was very keen endoscopic surgeon. I do endoscopic surgery now, but I take it with some reservation, thinking, is it really going to help? So you need to treat 12 patients to get one pregnancy. So number needed to treat is 12. And please remember this for minimum to mild endometriosis, because for moderate to severe endometriosis, that figure is different. ASHE guidelines suggest that operative laparoscopy with adhesiolysis along with excision and ablation should be done rather than diagnostic laparoscopy. And that has been supported by Cochrane database systemic review. But having said that, Reproductive Medicine Online article said complete surgical removal of endometriosis, whether it should improve the live birth after ART is not very clear. So we cannot really completely remove endometriosis. We can only make it maybe 95%, maybe 90%. You cannot remove endometriosis, microscopic endometriosis. So they are saying if you are planning for ART, surgery is not essential. If you look at moderate to severe endometriosis, as I told you, it is unethical to do a multi-analysis, randomized control trial or meta-analysis because it's unethical to randomize. And all the uncontrolled studies published before the millennium was claiming the 30 to 67% pregnancy rate. But after the millennium, when we are much more rational, we have found the success rate is about 25%. But that's not bad. If 1 out of 4 patients get pregnant, fair enough, you can give surgery because many patients cannot afford ART. And if they're not successful with surgery, then you go for ART. Now, as I told you, that there's a negative correlation between the stage of endometriosis and the pregnancy rate. So negative correlation means higher the stage of endometriosis, lower the success rate. That's obvious. That's obvious. And even by surgery, that couldn't be reversed. Now, as regards efficacy of infertility treatment, conservative surgery is better than no treatment. Adhesive disease and endometrioma more than 4 centimeters should undergo surgery treatment. Cumulative pregnancy rate may be 60% or 35%, depending upon whether it's moderate or severe. So after surgery, you wait for 1 year. If 60% of your patients are pregnant, wow, that's good. But that really doesn't happen. It's hardly 25%. But highest pregnancy rate happens in the first year. So if they're not pregnant, there's no point waiting after a year. Now, the most important statement regarding surgery is repeat surgery has very little role to play. So if you get a patient who already had surgery elsewhere, please don't repeat it, because that will actually reduce the ovarian reserve. I was just listening to Dr. Jaideep Tank in a different webinar, who is obviously contesting for the president's post, next Foxy president, a very good friend of mine. And he said, one of the reasons many of our infertility patients have poor ovarian reserve, because we have done multiple surgery on them. If it is necessary for pain relief, fair enough. But just for infertility, we have to think about it. Now, there is a very nice way of assessing the outcome of treatment that is called Endometriosis Fertility Index. And higher the index, that means lower the disease, obviously higher the live birth rate. And that will continue 46%, 58%, 91% after 5 years. And if the score is lower, then obviously the success rate is much less. Now, ASHA guidelines suggest that if we have stage 3, stage 4 endometriosis, then we should excise the endometrioma capsule rather than just do a drainage and electrocoagulation. So when someone is very junior, very young, not experienced, often endometrioma is drained and people do a little bit of coagulation, but the chance of recurrence is very high. So we should try and remove the capsule of endometrioma as much as possible. But having said that, if we try to remove completely, we would also strip off the normal ovarian tissue. If the endometrioma is more than 4 centimeters, it should only be done if there is no question of pain relief. If we cannot access the ovary, it should be done. Now, the surgery for endometriosis, as I have said, has the risk of reducing ovarian function with the possible ovarian loss. Sometimes we may have to remove the ovary altogether, particularly, once again, if there is previous history of surgery. So in addition to that, there are 3 types of endometriosis. One is surface endometriosis, one is ovarian endometrioma, and the last is deep nodular endometriosis in the POD, the rectovaginal septum endometriosis. And effectiveness of removal of deep nodular endometriosis and infertility is not there. It is good for pain relief, but just to do that, to improve the success rate of ART or infertility treatment is not correct. Now, hydrosalpinx, of course, we should treat. 75% patients, it has been reported by the Cochrane that 75% women with endometriosis who had multiple failed IVF cycles. So there are many patients who come to you who never had surgery, they had multiple failed IVF. Apparently, after doing surgery, a large number of those patients may get pregnant. So we cannot say just surgery is the only treatment or ART is the only treatment. When you have an endometrioma, we will excise it. Best thing to do is partial cystectomy and ablation, because it's actually a pseudocyst. It is the cyst arising on the surface of the ovary. So one side of the cyst, which is attached to the ovary, is actually so adherent, if you try to remove it, you will strip off normal ovarian tissue. And therefore, excise as much as possible and ablate little bit which is attached. The surgery success rate to improve fertility is actually modest. And here you need to do 4 laparoscopic surgery to get 1 additional pregnancy. So number needed to treat for these patients are 4 in contrast to 12 with early endometriosis. Now, there are many negative impacts of surgery. Absence of plane of cleavage, so healthy ovarian tissue will be removed. In 97% of the specimens histopathologist examined for ovarian endometrioma surgery, 97% has ovarian tissue, healthy ovarian tissue in the specimen. So we are actually removing part of the ovary. And there is a direct relationship between the cyst size and the amount of ovarian tissue we are going to damage or remove. The bigger the cyst, bigger the damage. Moreover, we do coagulation and hemostasis during surgery, which will damage the blood supply and ovarian function. So ovarian reserve is something which is very pertinent now. We look at AMH, we look at antral follicular count. So at the end of the day, we have to measure all this before the surgery and after surgery, see how much changes has happened. If it is a unilateral endometriosis or endometrioma, then AMH value will be normal. So antral follicular count is a better predictor. And repeatedly, everybody is saying it again and again, repeat surgery is worse and further loss of ovarian value. I hope at the end of the talk, everyone can go home with this message. The repeat surgery of endometriosis should not be done if it is for infertility. I'm not talking about pain relief. For pain relief, I have seen my Professor Christopher Sutton doing laparoscopic surgery on the 14th time on a patient, on the 14th time. And as a junior doctor, when I went to take the history of this patient and I was explaining the laparoscopy, she smiled at me and she said, "Doctor, I know more than you about laparoscopy because I've had it for 13 times before." It's like cleaning your teeth. You go to the dentist and have flossing. Chris Sutton used to do laser laparoscopy, and many women in UK would come every year, have a little bit of surgery and not take medical therapy. That's for pain relief as well as for infertility. Now, ovarian reserve will actually go down after 1 month of surgery, and in many cases, it will actually get better after 6 months. So ovary has a potential of regaining it. Now, with the medico-legal circumstances, now we have to have AMH values done for any patients who are undergoing surgery. So the take-home message as regards surgery is infertile patient with endometriosis may benefit from laparoscopic conservative reconstructive surgery. I said may benefit. I said should always benefit is not true. So need for surgery has to be individualized. Minimal mild endometriosis, its benefit has been confirmed by randomized controlled trial and meta-analysis, but that in severe to moderate endometriosis is limited. And I reiterate, it may be detrimental in some. Now coming to ART, minimal mild endometriosis, normally patients undergo ovulation induction with clomiphene, letrozole, gonadotropin for maybe 1 year, 1.5 years, including IUI cycles. And then if it doesn't have work, then only they come for ART. Small endometrioma, exactly the same. You don't need to do, and there is no need of prior laparoscopic surgery. In many patients, if the tubal function is compromised along with male factor, then obviously ART is taken much earlier. Whereas with moderate to severe disease, ART is the treatment of choice without any medical or surgical therapy. A medical therapy is putting a brake in your car whether your car cannot run, so you cannot reach your destination. So the surgical therapy and ART are the treatment for infertility and endometriosis, and not medical therapy like GnRH analog, oral contraceptive pill, Dydrogest, Dynogest, because all these are actually suppressing ovulation. Now this graph nicely shows that blue is the control ovarian hyperstimulation. Your success rate will gradually go up and reach about 40% after 6 months. Whereas if you do IVF straight away, then your success rate, even in the first cycle, can reach 50%. And even after 3 attempts, it will reach about 75%. Some patient will undergo, in green, they will undergo control ovarian hyperstimulation with or without IUI, followed by IVF. And their success rate is very similar to pure IVF. So there is no harm in trying control ovarian hyperstimulation and IUI for 3 to 6 cycles. Now, this is what it happens, comparing IVF and IUI separately in different stages. And you will see if you do IVF, the success rate is much better. So if your patients can afford 3 cycles of IVF, that is best. But if they cannot afford them, give them control ovarian hyperstimulation and IUI for the first 3 cycles, followed by IVF. Now, there are actually risks of doing ART in endometriosis, because control ovarian hyperstimulation causes hyperestrogenic state. And with hyperestrogenic state, there is a possibility of recurrence or aggravation of endometriosis if you do it repeatedly. Now, second thing is, while doing egg collection, if you puncture the ovarian endometrioma, I have had 2-3 cases. Now, within the endometrioma, there is gram-negative, there is anaerobic organism. So by draining it, you have pelvic infection or pelvic abscess. So that is something we have to keep in mind. There may be inadvertent damage to the surrounding organs, because in endometriosis is bowel adhesion, bladder adhesion. So when you're doing egg collection, if you have intestine next to the ovary, intestine will move away, but that is not going to happen. I had a case of ureteric injury during egg collection, because the ureters were really adherent to the ovary and they were dilated. But all these things, I say that if you do not want any complication, then don't operate. There's a saying in the operative surgical book: if you do not want complication, then sit at home, sit in your chair and just read. Don't come and do surgery. But if we can identify the problem and rectify the problem and justify to the patient why it happened, then you are right. Now, my professor Christopher Sutton used to say, I often said, sir, we take so much risk and there may be ureteric damage. So he said, okay, that is true, but it is also true the ureters are already damaged. Ureters are already adherent to the ovary. So by doing the surgery, you're actually improving the outcome. Otherwise, they will develop hydronephrosis and kidney damage. And it is very difficult. He used to smile and say, it's very difficult to prove in the court of law whether you damaged the ureter or endometriosis damaged it. Now, finally, avoidance of surgical intervention may look the possibility of associated ovarian malignancy. Although rare, some patients of endometriosis will have associated malignancy. And if you do not do surgery, you do not do biopsy, you may miss that. Now, we need to prepare our patients before ERT. We can give medical therapy with OCPIL. We can do GnRH analog. Now, the question is, if you give this, again, you are putting a brake. So you are suppressing the ovarian function. So why we are treating them? We want to make the environment healthy. But in order to make the environment healthy, we are suppressing the ovarian function. So the current concept is you do ovulation induction, you collect the oocytes, prepare the embryo, freeze them, put them on 3 months of ovarian suppression, and then transfer it. So environment is important for the embryo. Environment is not important for egg or sperm because they are being fertilized outside the body. When they're trying on their own, this hostile environment we talk about in endometriosis is very much applicable, even in IVF, when we are doing embryo transfer. So I hope I've been able to explain that why we do what we call sandwich technique. So you collect the egg, fertilize the embryo, that's one side of the bread. And in the middle, you put some jam or jelly or butter, which is the suppression of ovarian function. And the other side of the bread is actually transferring your embryo in a frozen, the frozen embryo in another cycle when the disease process has been suppressed. Now, the question is whether the new medical therapy like letrozole, anastrozole, and cabergoline is going to do any good. We don't know as yet. Surgery should be better avoided. I've already said it so many times, particularly if it's a patient is older, asymptomatic, low ovarian reserve, bilateral ovarian endometrioma, and also if they had prior surgery, because surgery will actually reduce the ovarian function and lower the outcome. Now, this is an algorithm. If the patient already had previous surgery, you don't operate on them. If the patient had surgery, then you can try GnRH analog. If the patient had previous surgery, you try with GnRH analog for 3 months. If there is no surgery, cyst is bigger than 5 centimeters, yes, we are going to operate. Cyst is less than 3 centimeters, no point doing surgery, go straight away for IVF. If the cyst is between 3 to 5 centimeters, just like previous surgery, we give GnRH agonist for 3 months and then go do IVF. Now, regarding endometrioma, the important message is it does not always impair outcome of IVF, of ART. So you don't need to really remove them. But on the other side, people are saying the endometrioma results in follicular depletion by oxidative stress, by necrosis of the follicle, by the apoptosis of oocyte. And also the ovarian damage is quantitative rather than qualitative. Now, I said at the beginning of my talk, the ovaries are not good. The eggs are not that mature or good. But now the recent papers are suggesting these patients will have fewer oocyte, but relatively unaffected quality. Quality-wise, the science is like a pendulum. On one time, they will say HRT is very good. And then pendulum will say, no, HRT is very bad. and then it will come back in the middle and say, okay, it is all right. Similarly, with infertility, endometriosis, sometimes we say surgery is good, sometimes we say ART is good. We have to take the science and believe it. Now, surgery, as I said, is going to damage, and therefore, we will only operate on the bigger cysts and which adherent ovary. Now, very interesting paper looking at the meta-analysis of all published study between 1983 and 98. They said number of oocyte retrieved as well as implantation and pregnancy rates are lower in those in stage 3, stage 4 compared to stage 1 and stage 2. Obvious. But another study showed implantation and pregnancy rate were lower in stage 3 and stage 4, or they are in comparison to tubal disease and unexplained infertility. So stage 1 and stage 2 is similar to any other. So a patient with tubal disease or unexplained infertility, their outcome of ART is similar to that of endometriosis stage 1 and stage 2. So we cannot just say all endometriosis patients are going to have low success rate. And why? We have now said it by endometriosis X-ray guideline that endometriosis itself does not adversely affect pregnancy rate by SART and HFEA database findings. Implantation and pregnancy rate are similar whether you use agonist cycle or antagonist cycle. Some people thought these eggs are not good, so you do ICSI as a routine, but that is not true. In the absence of male factor, you don't have to do ICSI. Now, a few more slides regarding the effect on oocyte quality. Now, this is a very interesting study. What they did, they selected the patient where they had unilateral endometrioma and other ovary is healthy. So they collected eggs and oocytes from these patients, and they found the fertilization rate, cleavage rate, and embryo quality is same, whether the egg comes from the endometriosis ovary or egg comes from healthy ovary. That is interesting, isn't it? And another paper confirmed the same findings, that intra-patient comparison within the same patient, one side endometrioma, other side normal ovary. The numbers of oocyte retrieved, M2 oocyte, and total embryos were actually similar. So, ladies and gentlemen, thank you for your patient hearing. I would just end with this take-home message: ART for endometriosis. We all believe that ART is the last resort for infertility patient with mild and moderate, with minimal and mild endometriosis. So minimal mild endometriosis, we do not have to jump and give them. They can have laparoscopy, they can have ovulation induction with letrozole, with gonadotrophin, with IUI, and then if none of this work, then take them through. Whereas in moderate to severe endometriosis, ART should be offered much earlier as a more effective alternative than surgery. Medical therapy has almost no role except ovulation inducing agents. So how can OC pill, how can GnRH analog help in infertility? Because they suppress ovulation. Efficacy of surgery in minimal to mild endometriosis has been confirmed, but it is not mandatory. It is not mandatory before starting ART. And the role of surgery in moderate to severe endometriosis is also limited. So it may be detrimental in some cases. So it's very interesting. In my 40 years of experience in the medical field, first 20 years, I believe the surgery is the best treatment. And in the next 20 years, I say, yes, surgery is effective treatment, but not necessarily the best treatment. Thank you very much, ladies and gentlemen. I'm really grateful for this opportunity. And I hope I will get the opportunity to continue this academic, journey of mine and sharing my experiences, do many workshops, organize many conferences with the different chapters of ISAR with your support and blessings. Thank you. Thank you, madam.